Hi, good day. I'm Latifah Wan Teh, a Bachelor of Medical Imaging part-time, cohort 1. The presentation today is for MRI 4133. The learning outcomes for MRI 4133, by the end of the discussion, students should be able to list the clinical indication for MRI brain and also neck, list of equipment needed for the MRI brain and also for the part neck, describe the patient positioning for the MRI brain, list and justify the scanning protocol needed for MRI brain, list and describe the patient and technical consideration related to the MRI brain, and lastly, list the image artifact related to MRI brain and ways to minimize or to prevent them. The presentation also can be accessed through the YouTube link. For the presentation, I would like to present and discuss about the MRI brain and also exclusive protocol for MRA circle of release, and a little bit for the neck, especially for the carotid MRA. The clinical indications for MRI brain. For this case, I would like to share the MRI brain and MRA brain circle of release for male patient 56 years old, case of sudden onset left-sided facial paralysis, left upper limb and lower limb weakness, and also patient with slurred speech. So the referring doctor to rule out the cerebrovascular attack. However, other indications for the MRI brain that has been conducted in our center, such as transient ischemic attack or TIA, cases for infection, inflammation, meningitis, encephalitis, neurodegenerative disorders, dementia, loss of consciousness, seizures, epilepsy, case of brain tumors, metastasis, abscess, cerebral lesion, brain stem lesion, headache, hemorrhages, trauma, vascular pathologies, congenital abnormalities, also post-operative follow-up cases, multiple sclerosis, and also demyelinating disease. Equipment preparation for MRI brain. In our center, we use MRI machine 1.5 Tesla superconducting magnet. We use a MRI machine model Siemens magneton Amira with biometric. Head and neck coil with 16 channel. Head and neck immobilization sponge. We also need earplug or ear cover, patient gown, patient belonging safety locker, MRI metal detector, either handheld or single pole detector or door metal detector. In the slide, this is the MRI 1.5 Tesla model Siemens magneton Amira biometric. Head and neck coil 16 channel, patient immobilization sponge, patient gown and safety locker, earplug and ear cover or headphone, patient leg support, patient strap, MRI metal detector, handheld metal detector, single pole metal detector, and door metal detector. MRI brain patient preparation. After receive the MRI request from the referring doctor, Radiographer must identify patient correctly and confirm part of the examination. If there is any doubt, please clarify with the patient itself and the referring doctor or the radiologist. Radiographer must perform MRI checklist for patient safety by using the MRI checklist form provided. Obtain the informed consent from the patient if required prior to the procedure. Note the patient weight and height. Ask patient to change clothes to the patient gown provided. Ask patient to remove all the metal objects including keys, coins, wallet, card with magnetic strips, jewelries, hearing aid and hairpin. Offer earplugs or headphones, possibly with music for patient comfort. Explain the procedure to the patient. Inform patient do not move during scanning. If the MRI scan requires intravenous contrast media administration, the blood test of urea and serum creatinine must be made available. Patient positioning for MRI brain. Patient lie in supine position and in head-first orientation. Place the patient head into the head coil carefully. Straighten the patient head with the chin relaxed. Center the laser beam over the glabella. Interpupillary line parallel to the couch and the patient head should be straight. The patient's eyes must be closed while using laser marking. For patient comfort and safety, the earplugs should be used for hearing protection. Immobilization pads and straps should be placed around the head to reduce noise and motion. Leg support pads should be placed and the alarm bell must be tested and given to the patient. In the slide, shown how we position the patient for MRI brain. Patient lie in supine position with head-first orientation. This is a gantry magnet which is contained of magnet 1.5 Tesla. This is a head and neck coil 16 channel. Both sides we have a display monitor. We also provide patient headphone with music, patient call bell. This is a comfortable patient couch. We provide a leg support to the patient, and this is a call and accessory cabinet. After we position the patient and patient is in the isocenter of the magnet, we acquire the localizer images. In our MRI, we call it a scalp scan. The localizer images will be automatically appeared after the scalp scan. This MRI system are aligned automatically by auto-align according to the patient head position. This can help the MR radiographer for easy planning or for the new MRI trainee to plan easily. So it will give us 3 scalp image for sagittal, coronal, and axial. Basic protocol for MRI brain in our center. Normally we start with brain T2 axial. We use the spin echo sequence with slice thickness 5 mm and slice gap is 1.5 mm. The slice orientation, we plan on the sagittal image. The scan line parallel to the line connecting to the anterior commissure AC to posterior commissure AC, or we call it ACPC line. So the scan range is from the vertex cover to until foramen magnum. So the T2 normally highlights the intensity of fluid, making better detection of any inflammation. Next is a brain T1 axial, also spin echo sequence with the slice thickness of 5 mm and slice gap is 1.5 mm. The slice orientation is same as T2. Scan range also same as T2. T1 images is to look for fluid full spaces in the body, CSF in the brain, and spinal canal. So T1 weighted imaging can also be performed while using the contrast media or gadolinium. For the brain flare axial protocol, we use a flare TSE. With the slice thickness is 5 mm and slice gap is 1.5 mm. The slice orientation is same as T2 and T1. Also same for the scan range. So these flare sequences are routinely used in the cerebral MRI for edema imaging. Another basic protocol for MRI brain is T2 coronal scan. So this is also spin echo sequence with the slice thickness of 5 mm and slice gap is 1.5 mm. The slice orientation for coronal T2, we plan on the sagittal image. We angle the position block perpendicular to the corpus callosum. The scan range is from vertex to the foramen magnum. And T2 also highlight the intensity of fluid, making better detection of inflammation. Next is brain T1 sagittal, also spin echo sequence with 5 mm and 1.5 mm gap. The slice orientation we plan on axial image. So we have to angle the position block parallel to the midline of the brain. An appropriate angle must be given in the coronal plane on a tilted head. And it must parallel to the line along the third ventricle and brainstem. So the scan range, of course, from vertex to foramen magnum. And T1 images is to look for fluid full spaces in the body for CSF in the brain and spinal canal. In this study, we perform additional protocol scanning, what we call it exclusive protocol, which is we perform a brain diffusion weighted imaging for the echoplanar imaging or EPI, with the slice thickness is 5 mm and 1.5 mm slice gap. So the slice orientation is same with the T2 or T1. The scan range also same from the vertex to the foramen magnum. And the DWI is an extremely sensitive for method for detecting of acute stroke. Next is exclusive protocol for this patient. We perform the brain MRE also. We use a 3D time of flight or 3D TOF with 0.5 mm slice thickness with -4 mm slice gap. So for the MRA, also on the sagittal image, we angle the position block parallel to the genu and splenium of the corpus callosum. The scan range for the MRA, the corpus callosum, from the corpus callosum up to the line of the foramen magnum. So the slices must be sufficient to cover the whole of a circle of release. For the MRI brain, must use the saturation bands over the axial block to reduce the venous contamination of the images. In the slide shown, the image planning for axial scan. The localizer images will be automatically appear after the scalp scan. So this MRI system are aligned automatically by auto-align according to the patient head position. This scan can help MR radiographer for easy planning or for the new trainee staff in the MRI environment. The yellow box is the desired images that we want to scan, and we plan the box, the blue box is what area that we want to cover. So the red line indicate for the axial we plan the ACPC line must be parallel to the block. Okay, and we also check with the coronal images. This is for image planning for sagittal scan. The yellow box indicate that desired images that what we want to scan, and the blue box indicate that what we have to plan from the axial images. We have to angle the block, the blue block, parallel to the midline of the brain. So we use the red line to indicate the block must parallel to the midline of the brain. An appropriate angle must be given in the coronal plane on a tilted head. So the blue box must cover the whole brain in the coronal images, and the box and the red line parallel to the along to the third ventricle. This is the ventricle and brainstem. This is how we plan the sagittal. For image planning coronal scan, the yellow block is indicate that coronal images, desired images that we want to scan. We plan on the sagittal images. You can see the blue box. So we have to angle the blue box or the position block perpendicular to the corpus callosum. So we ensure the red line and also the blue block must perpendicular to the corpus callosum. And we check with the axial images, make sure all the brain is inside the blue box. In the slide shown set of normal images for axial scan. So this is an axial T2 weighted, axial T1 weighted, and axial flare. For axial T2 weighted appearance, the fluid become bright. White matter is darker than gray matter, and gray matter of course is gray. Bone, the appearance is dark. Fat is bright. For the T1 weighted images appearance, the fluid is dark. White matter whiter than the gray matter is gray. White matter is whiter and gray matter is gray. Bone dark. Fat become bright. And also if there is any moving blood, it will appear dark. For axial flare appearance, the fluid also dark. White matter darker than the gray matter, and the gray matter appear gray. Bone appear dark. Fat become brighter than bone. If there is any moving blood, it will become dark. This is how the T2, T1, and axial flat appearance. This is the appearance of the sagittal T2 image and sagittal T1 images. And this is the set of normal images for coronal T2 scanning. I would like to share the pathological image that we had conducted at our center. This is cases of acute middle cerebral artery infarction or acute MCA infarction. This is an axial section of the brain for axial T2 diffusion weighted imaging at B value 1000 and ADC map. So ADC is apparent diffusion coefficient. So the typical appearance 24 hours post-stroke for axial T2 is shown hyper intense. For the DWI at value B1000, it also hyper intense, and on ADC map is shown hypo intense. For the pathological image of brain metastasis in the MRI brain, as you can see in the slide, there are an axial and coronal section of brain pre and post contrast. In the coronal T1 image, metastatic lesions are iso-intense to mildly hypo-intense. However, the lesion appear hyper-intense in T2 weighted images or with fluid attenuation inversion recovery. After the contrast media administration, a solid nodular or irregular rings pattern will be enhanced in the T1 weighted image. In MR imaging also has some limitations in terms of patient considerations and also artifact. So this could reduce the image quality. Therefore, I will highlight the most frequent event in the MRI brain of the patient issues and also artifact at our center for the MRI brain scan. The issue is a patient is restless and keep moving during the brain scan. So how to overcome that? We immobilize patient maximally by using an immobilization sponge and patient strap. We also use GRE sequence but low SNR. We use a force protocol sequence or uncooperative protocol. So in our center, we use the force protocol with acceleration mode. We call it blade. So this is a Simon protocol, as you can see in the slide below. This is a standard protocol, and this is a fast protocol. So we can see the difference in the metric size, NEQ, but the SNR is the same. Wrap around artifact or aliasing artifact. This is the common artifact that happen at our center. It occurs when the field of view or FOV has been used is smaller than the body part being imaged. So how to overcome that? So just simply increase the SOV. However, when you increase the SOV, the spatial resolution will decrease. So we will increase the phase and frequency encoding access, but it will increase the scanning time. Next, the common artifact that occurred during the scan is a motion artifact. So the source of motion artifact is normally it is a patient-based artifact that occurs with a voluntary or involuntary patient movement during image acquisition. So the rectification, we ask the patient do not to move. Use the fast sequence protocol. Selection of phase encode direction. For example, in the brain scan, when we do the orbit scan, axial brain images are usually phase encoded from left to right, so that the artifact from the eyes do not spill over into the brain. We also, to reduce the physiological motions, reduce with glucagon for certain MRI exams such as abdomen and pelvis. This glucagon has to be requested by the doctor. And lastly is a sedation. So the sedation is a last choice, and we not do it as a routinely, only for the highly anxious patient. So this also must be discussed with the referring doctor and radiologist. In addition, I would like to present the exclusive protocol of MRA circle of Willis and a little bit about carotid arteries. This is a localizer images for MRA circle of Willis. The localizer images will be automatically appear after the scout scan. Three plane, sagittal, coronal, and axial, must be taken in the beginning to localize and plan the sequence. Image planning for MRA circle of Willis. Plan the axial 3D block on the sagittal plane. Here. Angle the position block parallel to the genu and splenum of corpus callosum. Genu and corpus callosum here. Slices must be sufficient to cover the whole circle of Willis from corpus callosum here up to the line of the foramen magnum here. Check the positioning block in other two planes. An appropriate angle must be given in coronal plane on a tilted head, perpendicular to the line of the third ventricle and brainstem. This is a third ventricle and brainstem. Using the saturation bands over the axial block will reduce the venous contamination of the images. This is the set of MRA circle of Willis 3D images reconstruction. After we finish the MRA brain, using the same coil without move the patient, we have to localize the images for MRA carotid. In this case, after completing the MRA brain scan, the carotid arteries or region of interest has to be in the isocenter of the magnet. Therefore, the region of interest will be moved to the magnet isocenter by moving the patient couch based on the planning here. A new localizer images will be taken afterwards. This is a 3-plane T1 weighted localizer. After we do the scout scan, the localizer images will be automatically appear after the scout scan. A 3-plane of T1 weighted must be taken in the beginning to localize and plan the sequences. For MRA carotid scanning, before we perform the 3D MRA carotid, we have to do a sagittal vessel localizer. We call it a phase contrast or PC 2D sagittal vessel localizer. We plan the sagittal PC 2D localizer on the coronal plane. Angle the position block parallel to the cervical spine. Check the positioning block in the other two planes. An appropriate angle must be given in the axial plane parallel to the spinous process of the cervical spine. Slice thickness must be sufficient to cover the neck from the right pinna to the left pinna. FOV must be big enough to cover the whole neck from frontal sinus down to the clavicle. After perform the sagittal phase contrast to the localizer, now we can plan a 3D TOF multi-slab axial 1 mm for the carotid artery scanning. Plan the axial block on the sagittal PC 2D localizer. Angle the position block perpendicular to the carotid arteries. Check the positioning block in the other two planes. An appropriate angle must be given in the coronal plane on a tilted neck, perpendicular to the cervical spine. Slices must be sufficient to cover head and neck vessel from corpus callosum down to the arch of aorta. Phase direction in axial scans must be anterior to posterior with at least 50% over the sample. It's very important to instruct the patient to avoid swallowing during the sequence acquisition. In our imaging department, we give 30 seconds after each scan for the patient to swallow saliva. This will avoid the motion artifacts in the neck during the image acquisition. Using saturation band over the axial block will reduce the venous contamination of the images. This is a set of MRA carotid 3D reconstruction images. After the reconstruction, the images become clearer and provide a diagnostic values. The references for my presentation, and thank you.